Here with the review of major depressive disorder by Dr. Shalan and Abbudi, consultant psychiatrist in the main Academy Medical City. As you know, depression is one of the worldwide and greatest public health problems. In the most recent iteration of the Global Disease Burden Survey, it was the third leading cause of disability worldwide for the women and the fifth leading cause of disability for men. That was in 2017. By some estimate it will move up even higher by these 2020 and beyond. It is a common condition depending on where you live and has a point prevalence somewhere between 5 and 15%. About 20% of this depressive disorder are within the bipolar spectrum. It is type 1, and if you have had mania, and type 2 if you had hypomania. Together, as many as 1 in 5 people will experience one or the other of these mood disorder across a lifetime. They are one of the major causes of workplace disability. They have a similarity or similarly bad impact on family life. For example, simply living with a depressed person is a risk factor for becoming depressed. Interestingly, as our society's economic circumstances changes or improve, depression rates tend to increase, so many does not protect you from a risk for depression. Importantly, the mood disorders are highly co-occurring with other common medical conditions such as heart disease or high blood pressure. They tend to amplify the morbidity of these associated conditions. Depression has a significant impact on longevity and by some accounts may cost people 10 years of life on average compared with non-depressed age control. I think importantly, 3/4 of people who die by suicide have either major depressive disorder or bipolar disorder, often untreated. Yes, since the 1970s, the diagnosis of depression has focused on defining the syndrome with its sign and symptom. This was first popularized with the APA, the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorder, the DSM, and the DSM-3 in 1980. We are now on DSM-5, which came out in 2013. The WHO also have the classification of the has followed the suit through the international classification of disease, the ICD-10 and the ICD-11. I think importantly, these refinements in classification, which really led to improved reliability, have not changed much over the past 40 years. There have been some subtle changes here and there, but basically we are talking about identifying a syndrome, a constellation of signs and symptoms that have come and have lasted at least several weeks and are associated with significant impairment. What is the syndrome of major depressive disorder? What is a major depressive episode? It begins with the mood changes, a sad or low or blue mood, most days over at least a 2-week period. then it must be accompanied by a pervasive loss of interest or diminished sense of pleasure, or at least four other signs and symptoms including low energy and fatigue, insomnia or hypersomnia, loss of weight or increased weight loss or increase, psychomotor changes, either slowing or retardation or agitation, poor concentration, suicidal ideation, and then a peculiar kind of pathological guilt, often associated with intrusive ruminations, thought about your failures, your shortcomings, how you have not measured up in life. Again, it is the mood change plus or minus the change in the motivation and at least four accompanying symptoms that really define as major depressive episode. Now let's think of it in broader terms. Sadness, one of the symptoms, is also a normal emotion. There are a variety of situations in life where we become sad, even though we do not have clinical depression. In some situations, the event that happened was so upsetting or so traumatic we might seek help for it, and then we call that an adjustment disorder. There is the mood change, but the person does not have the whole syndrome. When that upsetting event is the death of a loved one, we may call it grief. If the signs and symptoms of depression are mild or not so intensive or not causing so many difficulties in one's life, we may just leave it at that, at grief, and not diagnose the depressive episode or not recommend treatment beyond support. So now we are in the major depressive episode. Again, the people with five or more symptoms, you can think of it following a spectrum from mild to moderate to severe with psychotic features. When you use a standard rating scale like PHQ, the 9-item patient health questionnaire, which has been popularized for use in primary care, generally people who are not clinically depressed score less than 10. People who are in the mild range score 15 or less, and people in the moderate range between 15 and 20, and the more severely depressed individual tend to score over 20. That means you have definite symptom on 5 to 7 different symptom criteria for the disorder. Again, nothing about the depressive episode tell you whether or not you have bipolar disorder. It is the experience of a separate, independent episode of mania or hypomania that define bipolar disorder. There are also people who can have a mixture of hypomanic symptoms within a depressive episode, and these are said to be mixed episodes. The first antidepressants were discovered within a decade of the recognition of the importance of the monoamines in regulating mood and sleep and appetite, and to some extent energy and motivation. So when the first antidepressants were discovered, it was within a few years demonstrated that these medications work through either modulating serotonin or modulating norepinephrine, or sometimes modulating both of these monoamine neurotransmitters. It was curious that the modulation started within hours or days of beginning of the antidepressant, but the antidepressant effect took weeks to develop. The simple model of restoring a deficit of a minor neurotransmitter was known from almost the beginning, not to explain why antidepressant work. Yet the monoamine deficit model remained highly influential. Much of the first 30 years of drug development was spent focusing on antidepressants targeting either the serotonin or norepinephrine or both neurotransmitter system. As technology improved, methodology improved, and we became better able to understand many different neural systems involved in the expression of mood and pathologies of mood, the complexity of these conditions was further developed. So by the late 90s, early 2000s, it was clearly known that there were other factors involved. This includes things as exotics, as cytokine or stress hormone, as well as other newer or more recently recognized fast response systems, such as the glutamate system. Indeed, it involved the brain's own resilience. The brain's ability to dampen down stress and to repair neural damage through neurotrophin, such as brain-derived neurotrophic factor, which is called BDNF, was beginning to be understood. This helped to explain why it took weeks, not hours, for antidepressant to work, because it was a complex multi-level system for different people and different levels of dysfunction. All of potential contributing factors were operative. The pathway then to find new antidepressants was opened. All sorts of different strategies were looked at, including medications that might alter stress mechanism like corticotropin releasing factor, or through modulating other damping system, the neurokinine, for example. Unfortunately, here we got to the start of the 21st century, and we were still left with antidepressants that principally modulated serotonin and norepinephrine. So by 2010, these newer, more selective serotonin reuptake inhibitors or serotonin norepinephrine reuptake inhibitors became the beloved first-line antidepressant because they were safe and relatively easy to use and were now available in generic forms, less costly forms. We have some other first-line antidepressant also. Bupropion is one that is used, is only the medicine that is said to be a norepinephrine dopamine reuptake inhibitor. I think mirtazapine, which indirectly work on norepinephrine and serotonin, is also not classified as a reuptake inhibitor. Because this medication can be good for sleep and can help restore appetite, this medication has a role sometimes as a first-line treatment for older patients. Pharmacotherapy is not the only useful treatment strategy for patients with major depressive disorder. There are various forms of psychotherapy that can be useful as pharmacotherapy, including cognitive behavioral therapy, interpersonal psychotherapy, and various forms of attenuated behavioral therapy that have been shown to have the same level of benefit as antidepressant medication across 12 to 16 weeks of treatment. Patient preference can play a strong role in moderating the benefit of these therapies. If a patient does not wish to take medication, psychotherapy may be a preferred option. Conversely, some people have little talent or interest in psychotherapy, and you pursuing pharmacotherapy may be the better choice for them. The key common element of these psychotherapies are helping the patient get focused, helping him or her to restore moral, and to get working on problem solving and getting back involved in the swing of things to increase their activity level and their involvement in the things that make their life worth living. Of course, these treatments are not mutually exclusive. Patient can take medication and start psychotherapy at the same time. In controlled study, combined treatment regime tend to have about 10 to 15% added benefit compared to one mode of treatment or the other mode of treatment. At least learn what went wrong with the treatment if you can. Pick your next treatment so that it can target a different aspect, a different target symptom, a different mechanism of action. Don't try to repeat nearly exactly the same strategy over and over when the patient become in telling you to that you may not be on the right track. Then each time think about the possibility that maybe for this particular person, psychotherapy is a better option than pharmacotherapy. I think that working through your treatments in a stepwise orderly way from the easiest to implement first line to more demanding and difficult to implement third and fourth line treatment is logical. Keeping track of progress, at least on a monthly basis, with some sort of reliable symptom scale, and dealing with side effects as decisively as you can are proven strategies to make sure that patients get better as quickly as possible. Treatment episodes that involve infrequent visits and don't involve careful monitoring are less likely to result in favorable outcomes than those that are more carefully and thoughtfully orchestrated. In this slide, you can see an example of this in a study called the Texas Medication Algorithm Project. You see two groups in each of the figures. Importantly, you can see the group that followed the measurement-based care algorithmic delivery of treatment stepwise following careful assessment at each visit had a significant advantage that was evident within 3 months of the onset of treatment. Keeping close track of our patients does make a difference. At about the same time the Texas Medication Algorithm Project was underway, another nationwide study was getting going in the United States, known as the STAR-D, stand for sequenced treatment alternatives to relieve depression. was a four-stage study in which everyone began treatment with a standard first-line SSRI, citalopram. Then, if they were not progressing, they were not improving, they had significant side effects, then they moved on to a series of up to 3 additional sequential experiments. Then the second, third, and fourth stages, treatments were randomly assigned. In the graphic that I have here, you can see that with each treatment stage, as you went from the second stage to the third, to the fourth stage, there was a decrease in the chances that the patient will show a good response to treatment. Importantly, not shown in this graph is that at each stage there was loss of people who just stopped coming. There are two consequences for not getting better and not getting the first treatment assigned right. Not only is there the chance that the patient will not get better, but also the chance that the patient will become frustrated or disappointed and drop out of treatment. The best chances for success are in those first 3 months, the second best chance in the next 3 months, and so on. You need to keep working and keep the person engaged. Try not to give up and try not to lose hope yourself. The STAR D study did illustrated the concept of treatment-resistant depression, developing right before our eyes because people came in for a new treatment episode at the end of year. About 25 or 30% of our patients had become clearly resistant to standard therapies. The concept of treatment resistant was borrowed from infectious disease maybe 50 years ago. In our case, it is not that we have an organism that has enzymes chewing up our medication, but simply that the illness is not responding to treatment that works for some proportion of people on average. We are talking about the description of the clinical course. Treatment-resistant depression, it's called TRD, is not a diagnosis per se. It is not a person either. It is a person's treatment history. These are important concepts because people with depression are better at hearing pejorative things. If you say this treatment failed, people can hear I failed again. It is not the person who has failed, it is the treatment that has failed. The FDA has determined that the minimum definition for a treatment-resistant depressive episode is non-response to 2 adequate courses of antidepressant medication in the current depressive episode. Would 3 be better or would 4 be better? You can argue about this. Importantly, in Europe and the US follows the same guideline that you are really looking to study new treatment working through novel pathways for people with treatment-resistant depression who have not responded to at least 2 trials with standard medication. If you look at what is available right now, what do we commonly use to manage people with treatment-resistant depression? It depends on what level we are at. Obviously, if an SSRI and SNRI have not worked, then in a next level you might use mirtazapine or you might use a combination of antidepressants. At the next level, you might switch to one of the older standard antidepressants, a tricyclic or monoamine oxidase inhibitor. Given the severity of the illness, if someone is treatment resistant and quite severe, you might accelerate the use of another strategy such as electroconvulsive therapy, which is the best proven strategy for severe treatment-resistant depression. Out at the level 4 or 5 treatment-resistant depressive episodes, now you are looking at experimental therapies or newly approved therapies, things such as intranasal ketamine or ketamine infusion, vagus nerve stimulation. Again, of course, FECT has not yet not been thought of so far. One should think of it. There are two common strategies used for people who have treatment-resistant depression at the initial or after two unsuccessful courses of monotherapy. The first one is combining antidepressant with the second one is to add a newer generation antipsychotic medication. Importantly, when you combine antidepressant, you can pick medication that have potentially complementary effects. For example, in mirtazapine is commonly combined with an SSRI or an SNRI, and similarly, bupropion is commonly added to an SSRI to try to broaden the effect of the antidepressant. Interestingly, we have two studies done at almost the same time that yielded quite different results, evaluating the value of combining antidepressants. In the figure on the left, you will see a study by Blair and colleagues. In this study, combining antidepressant was really valuable and useful. The various combinations of antidepressants that I have described were all superior to monotherapy in the study with fluoxetine. On the right, it is a study that looked at several of the most commonly used antidepressant combinations. The combination of venlafaxine and mirtazapine, and the combination of bupropion and escitalopram. With escitalopram alone, I hope you can see that unlike the Blair study, in this large-scale multi-center study, there was no value for routinely combining antidepressants. So, which version is true? Which version of the truth do you want to believe? I think I know the answer. I believe that in the large-scale study, when the doctors combined antidepressants, they tended to use relatively low doses of both antidepressants. In the smaller study, the study by Blair and colleague, there was the tendency to use full doses of both antidepressants. The take-home message might be that if you are going to use two antidepressants, unless there is a worrisome metabolic interaction that you are watching for, it is important to make sure that patients get adequate exposure to both the drugs in the regime to ensure that they have the best chance of responding. As I mentioned, the second leading strategy in the US for people with more middling levels of treatment resistant depression is to add a newer generation antipsychotic as an adjunct to the antidepressant. And this is a proven strategy. It began with the combination of olanzapine and fluoxetine, but now includes a large number of other newer generation antipsychotics, including aripiprazole, quetiapine, brexpiprazole, and probably also risperidone and cariprazine. Of course, which of these medications are approved for this indication depend on where you are practicing, but the evidence is strong across a fairly large number of drugs that have relatively different receptor profile. I think these medications are complementing the effect of antidepressants. In fact, some of these second generation antipsychotics might actually, at lower doses, be thought of as antidepressants themselves. It is important to keep in mind that the newer generation antipsychotics, even at relatively lower doses, have important side effect issues that you must watch for, such as metabolic factors, weight gain, and other. You need to make sure that you have got a good weight and that you are monitoring this and keeping track. If the patient has any risk for dyslipidemia or for diabetes, that you are keeping good track for this as well. Importantly, if it is not working, discontinue the medicine and move on. You don't want to continue exposure given some of the risks. If it is working, you want to be judicious about how long you continue the therapy, because there is evidence that although fortunately rarely, some people will develop tardive dyskinesia and continue long-term therapy with a newer generation antipsychotic. I mentioned that there has been a lot of work trying to find different mechanisms to complement the mechanism of the newer SSRI and SNRIs. We have had medications that have been triple reuptake inhibitors involving dopamine, corticotropin releasing factor antagonists. Some work has gone on new serotonin receptor modulators, nicotine partial agonists, the neurokinin antagonist for substance B, melatonin receptor antagonist, and so forth. The most promising development so far in terms of newer mechanisms to treat again came with the accidental discovery that involved the recognition that the old standard anesthetic ketamine given intravenously at about 1/4 the normal anesthetic dose could have a rapid and dramatic antidepressant effect in a time course that was unrelated to its more intoxicating kind of effects. As you many know, ketamine is a controlled substance in the many countries. It is called a Scheduled 3 compound. That is a level of surveillance comparable to a benzodiazepine. Importantly, the antidepressant effect of ketamine intravenously at about 0.5 milligram per kg lasts for about 4 to 7 days. They are not permanent. Invariably, people who show a rapid acute response will start to relapse if they are not having regular infusions. So, finding a strategy that can sustain the effects of a series of ketamine infusion has been a goal. There is no doubt about the benefit that this figure, which comes from a meta-analysis done as part of a systematic review conducted by one of the task force of the American Psychiatric Association, shows just how consistent and reliable the antidepressant effect of ketamine infusion are. Now the hard work begins. How long should it be continued? Are there better? Are there better ways of administrating it? What can you do to magnify or to extend the response and reduce the dependence or the need to continue this treatment on a long-term basis? One strategy was to go away from infusion and to make the drug more readily dosable for a broader array of psychiatric practice. In the first new type of antidepressant treatment coming from the observation with ketamine, infusion was approved earlier in 2019. This is an intranasal delivery of S-ketamine that is one of the enantiomer of ketamine, which is a racemic drug. The intranasal delivery is based on the notion that 84 mg intranasally, approximately about 0.4 mg per kg. So it is comparable to the average dose that is used in ketamine infusions. However, there are some key individual differences here. There have now been multiple positive studies, including a couple inpatient studies that focus on more severely depressed patients with suicidal ideation. I think, interestingly, the European agency is reviewing this ketamine has given tentative positive review in treatment-resistant depression. Although at the time that I'm here, the final approval for use in Europe and elsewhere in the world is still pending. What kind of effects can you see with intranasal S-ketamine? Is it comparable to what you see with intravenous ketamine? What are some of the considerations? The figure here put up is showing the drug placebo differences in response and remission rate in pivotal studies. There is about 15 to 20% advantage for drug over placebo. Keeping in mind that all of these patients are receiving a newly administered antidepressant concurrent with esketamine in these studies. The number needed to treat to benefit here with this kind of drug placebo differences is on the order of 5 to 7, which is a real finding, and this is important. Most importantly, it is meaningful often within the first week of or two of a treatment that people see benefit. This is a real positive effect for a subset of patients. Obviously, it does not treat everyone. I don't know exactly how closely intranasal ketamine would compare to infusion ketamine. The direct head-to-head study has not yet been performed to answer this definitely. I think that you do get reliably more rapid drug exposure with the intravenous infusion. At the same time, there are the difficulties that go with finding the infusion clinic and the price of putting an IV set and so forth. So there are some mitigating factors. Importantly, intranasal ketamine has a time-limited effect, typically 4 to 7 days, just like infusion ketamine. Intranasal ketamine has evidence of favorable relapse prevention in a pair of studies that were done together. One focusing on a patient with stable remission, the other subset focusing on people who were better but not well, incompletely remitted patient. As you can see in this in the side-by-side schematic, the actual drug placebo difference, although statistically significant in both studies, was actually larger and more meaningful for the subset who had less perfect responses, the incompletely remitted patients. We don't know yet the best way to see from weekly to every other week or to monthly treatment, and what a new treatment might be brought on abroad to try to strengthen or improve outcomes. What we do now is that the effects are more sustained across time, that people don't seem to be showing tolerance to the effect. Importantly, in these long-term studies, even though this is a controlled substance, there was no evidence of a drug misbehavior or drug seeking or patients developing addiction in the course of the long-term treatment. In many practice, many seniors use this ketamine infusion and esketamine for patients who are out of the level of 3, level 5 of treatment resistance. Both are expensive treatment. Esketamine is tied to a very careful and thoughtful risk evaluation and mitigation strategy that is a partnership between the prescriber and the manufacturer to ensure that there is a common registry, that common standards of safe practice are followed, and that there is no chance of a drug diversion or drug misuse. For particular patients, some may prefer the IV intravenous infusion delivery over the intranasal. But I think that many people prefer the convenience of the intranasal form, which can be done at a modified doctor's office and does not require an infusion subset. There are a number of investigational compounds on the horizon, some of which are also glutamate targeting treatment like ketamine. This includes the R enantiomer of ketamine, R-ketamine, which is in preclinical trials, as well as a novel compound called lancimine. This originally had a positive phase 2 study, followed by a failed phase 3 study, but now the drug has been revived and is being re-evaluated. Other great interests are the intravenous gamma aminobutyric acid, allosteric modulator treatment that we call brexanolone, which was also approved earlier in 2019 as a treatment for postpartum depression. Importantly, the bioavailability problems that require brexanolone to be administered intravenously are not apparently limiting for an analog of this medication that is now called zuranolone, which may be orally administered. Zuranolone is being studied pretty vigorously in the United States now in the clinical trials of patients with major depressive disorder. These medications, which have a complementary mode of action that works through the complex glutamine GABA interaction, may provide yet another useful pathway for a subset of patients who don't benefit from standard therapies. On the more exotic end, there is a combination of an old standard antidepressant, bupropion, along with the active ingredient of cough syrup, dextromethorphan. Dextromethorphan's metabolism is actually blunted, and in combination, you get another orally administered drug that has an NMDA receptor antagonism kind of effect. Finally, there has been some receptor antagonism kind of effect. There has been some renewed interest in psychedelic drugs as putative treatment of depression. Psilocybin is now being studied both in US and UK and as a possible treatment for more advanced stage of treatment-resistant depression. This is not just people dropping a magic mushroom. In this case, this is a pharmaceutical grade psilocybin given in a very careful and controlled way. Importantly, during the time that the person is having a hallucinogenic experience with psilocybin, they are being guided in examining their issue by a trained therapist. It is a guided discovery method of trying to treat depression through psychedelic experiences. If you were around in the early 1960s, there was some work of this nature going on then that did ended when other better proven non-controversial or less controversial treatment began to be studied. In conclusion, our depressed patients' lives can be greatly improved by recognition and careful treatment. We begin with antidepressants that work through serotonin and norepinephrine pathways, not unlike what we began to do 40 or 50 years ago, except that the new ones, which are now inexpensive, are safer and easier to prescribe. We have a lot of reasonable second line strategies for patients who don't benefit from monotherapy with an SSRI or an SNRI or another antidepressant, including combining antidepressant and using newer generation antipsychotics. Importantly, the discovery of the NMDA antagonist drug Ketamine's antidepressant effect has led now to the introduction of intranasal ketamine and may well lead to a number of other interesting discoveries done at the road. As the discovery of brexanolone's antidepressant effect in women with postpartum depression set the stage, It is also possible in the near future that we may have yet other novel targeted antidepressants available for patients with the most difficult forms of depression to treat. Thank you.